The next company to present is Cinclus Pharma, and we're joined by their CEO, Christer Ahlberg. Cinclus is a Swedish, currently unlisted clinical stage biopharma company developing small molecules for gastric acid-related diseases. It's got a lead asset, linaprazan, in a phase 2 study for GERD currently. Linaprazan may be a familiar name to some as a former AstraZeneca drug candidate, and Cinclus also a familiar name to some as a link portfolio company. I'll hand over the word to CEO Christer.
Okay, thank you very much. Thank you for the introduction. We can go on to the next slides, please. And next again. As you mentioned, I'm Christer Ahlberg and I'm the CEO of the company. And today's presentation will be about Cinclus Pharma. I will guide you through, first a short introduction of the company and also our therapeutic area where we are focusing on, and also our lead candidate, linaprazan glurate, and the development steps for the future and the strategy for the future. So that will be the next 20 minutes. So please go ahead to next slide. And next. Short presentation of myself. I have been within the company since last summer, more than 25 years within the pharmaceutical industry. Recently I came from Sedana Medical, which I took to the, which I made an IPO for 5 years ago, and also got the approval of their therapy. I also worked as a CEO for Unimedic, one of the biggest company within the MedCap group. Also established Eisai, a Japanese company here in the Nordic and Baltic as CEO. Also during the time when Eisai and BioArctic had initiated their collaboration. I was also part as a marketing head of MEDA in the beginning of the MEDA journey. I was headhunted by Anders Lönneden from AstraZeneca where I started my career. I also participated in the launch of Nexium. So that's my short history. Going to the next slide. So looking into Cinclus Pharma, as we already heard from the beginning, we have one asset, very interesting asset in a drug candidate called linaprazan glurate, which is addressing a large unmet medical need within the gastric acid-related diseases. Market potential is huge, of $5 to $10 billion annually for our targeted segment. Our candidate do have a very interesting profile with the superiority efficacy potential and interesting pharmacokinetic profile. The ongoing phase 2 study is coming to an end, and we are estimating to have a top-line result of the summer here. And the clinical program by itself is also de-risked quite a lot, I would say. Most likely, we have the active metabolite linaprazan has been tested in more than 2,500 subjects by AstraZeneca, and also within a lot of animal studies before. We have an excellent biomarker which is actually predict the clinical outcome later on. I will show you soon. We have a good patent situation, 34, and with the additional patents valid submission, and if they come through, then we will have approval until 4041. Huge experience within this field in the company. Both CSO and CMO have been part of the huge successes of Astra and the development of Losec, Nexium, and linaprazan. So definitely we have a potential to become best in class and a future global market leader here. So next slide, please. I will also, before going into any other details, I will give you just an understanding of this market, so you understand the different, the importance, what we need to do here. Gastric acid-related diseases have always been a very attractive market for many decades, but each paradigm shift has been followed by that you increase and improve the acid control in the stomach, where you how long time can you stay above pH 4 in the content in the stomach. And the better control you have, the better chances you have to get a market leader position. That was the reason why PPIs became so popular, and also Losec became the biggest drug in the world, as well as the follower Nexium also became the biggest drug in the world. And that is also one of the reasons why the new generation and the new class, PCABs, which is now launched in Asia and especially in Japan by Takeda, where you're also improving the acid control even better than PPIs. And now you can already see that Takecab, which is the Takeda's PCAB in Japan, has the market leader position. And actually, they have selling for $1 billion only in Japan, and it's now the biggest drug in Japan all over the market. So that's enormous, actually, I would say, showing the potential. And our PCAB, which is representing the same class, a new class, actually have the potential to show even better acid control. So definitely, it's a very interesting product. So next slide, please. But before going into details, I just want to give you some updates of the disease. Next slide. This is a not very complicated disease, but patients suffering a lot due to erosive gastroesophageal reflux disease. And the intention with the system here is that it should be one-way direction. All the content in the stomach should go in one direction, not going upwards. And that is the problem when the ring muscle between the stomach and the esophagus doesn't work as it should. When stomach content goes up in the esophagus, and that gives very severe symptoms sometimes, but also erosions in the esophagus, which is not good. There are different alternatives to treat this. You can do it with surgery, not very popular these days. But this was something that when PPIs came on board, they succeeded actually to reduce the pH or increase the pH level in the stomach to above 4. Which is important, because if you are above 4, you don't get any erosions. But the problem with the PPIs, they couldn't do it for 24 hours. Approximately 12 hours was but they were very effective in 12 hours there, unfortunately. But so what we have seen is that approximately 30% of the patients are not fully sufficient treated with the PPIs currently. So there is a huge group with the unmet medical need of 30% of the current treatment group. Next slide, please. So our focus will be the erosive patients suffering from this disease. And that will be the initial focus for our indication ambition as well. Next slide, please. So looking in the indication aspiration we have is to go for the full grade, full E-GERD indication, all different grades from A to D, different severeness of the disease, both the healing phase, but also the maintenance to prevent relapse and also relief of symptoms. So that will be the indication, but our focus will definitely be on the 30% that is not sufficient treated by PPIs and the most severe E-GERD, and patients that actually need to improve the quality of life and symptom relief. Next slide, please. Looking into the market potential here, I mentioned 5 to 10 billion US dollar, and that is calculated on this epidemiologic data here. If you look into North America and Europe only, this is a huge very common disease. 175 million people are suffering from this, but and 40% of them are suffering from the erosive disease then. So that is the indication, the 70 million people in Europe and in North America. But the focus target group will be the most severe, C and D grades, and patients that are not sufficient treated with PPI. So we're talking here about approximately 18 million patients. And with an average daily treatment over a year of 100 days, and the price of $7 per day in US and approximately $2 in Europe, gives you market potential of $7 billion US dollar. And then, of course, you have an upside of in the rest of the world, which is this is also, I mean, this is commonly used also everywhere in the world, but that's definitely an upside. So going to next slide. Just going through the substance somewhat, and next slide again. I mean, I don't want to go too much into the details here, but this substance is developed by Astra, and especially the active metabolite linaprazan was developed by AstraZeneca. The linaprazan was a fantastic, effective drug. They had, but after, and they actually, the intention was that this should be the successor to Nexium. They had obviously two problems with linaprazan, which they faced after the phase 2 studies. Short duration and a peak Cmax, which really peaked initially after the first dose. They tried to compensate the short duration by higher doses, but since you had this huge peak in the Cmax, also gave them some challenges when it comes to side effects. So our founders, Kjell Andersson and Mikael Dahlström, the inventor of linaprazan, they was employed by Astra during that time and was part of the Astra journey for many decades. They started to find different solutions on these two issues, and they actually found a solution, and they made a prodrug, which actually prolonged the duration significantly and decreased the Cmax, the peak, by 75%. Which means that you actually mission was completed. So now we had a substance that actually was had a long duration and full acid control without safety or side effect issues. But the problem was that Astra, in parallel to this, had decided on highest level to actually stop working with the GI business area. So they decided to not continue with the GI business at all. And during that time, it was a possibility to have some kind of management buyout of the substance, and we could actually establish and they founded Cinclus Pharma. So going to the next slide. And the biggest difference between a potassium competitive acid blocker, PCAB, which is our class then, the linaprazan glurate class, compared to PPI, Losec and Nexium class, is the main difference. I will not go through. It works approximately the same, but there are some main differences clinically. As I mentioned initially, is that PPIs only have a half-life of 1 to 1.5 hours, which is way too short to be effective over 24 hours, even though you take three doses per day. And the problem also is a very slow effect onset, and takes 3 to 5 days to get full effect. And this should be in comparison to a PCAB where you have 10 hours with our in half time, which give you full 24 hours control, and you have a very fast onset. You have full effect within 1 to 2 hours. Huge difference. Going to the next slide then. I also mentioned about the excellent biomarker. This is also important to understand to predict the future studies. This curve is the result of decades of science and a lot of studies, and it shows the correlation. If you can keep the pH 4 above 4 over 24 hours, all patients will be treated and healed from the erosions. That is a very, very strong correlation here. So you know, if you can fix 24 hours acid control, then you heal the patient. So going to the next slide, looking into how the drugs are succeeding with this. Looking into the left paragraph is Nexium. Here you can see the green curve is the first dose, showing very slow effect. That you see the time after dose up to 24 hours, and then up to the pH 4, and you see the dotted line. That's the borderline of pH 4, which you need to come above to make sure that you heal the patients. And the first dose is barely coming up above pH 4, very slow onset. After 5 days, you are quite good in that, but still during evening and night times, you have problem to achieve pH 4, above pH 4. So many hours without acid control. Looking into Tachycab, our competitor in the new first PCAB came to the market. You have a similar curve, actually. The difference here is that you have already after first day, first 2 hours, acid control about pH 4, but you're dropping again late evening and early night. This is not optimal for the most severe patients. Going to the next slide. What we can see here is the comparison when what we have done in our studies. We can see that you have a fantastic curve when you have the right dose. You have full control in the yellow curve that obviously give you 24 hours acid control. No, you don't drop below. This is our drug. This is linaprazan glurate, and this is interesting to see. If you compare that to the next slide, between the different dose, of course, this will have a clinical effect differences, and this is what we are now looking into in the phase 3 studies to show. And looking into the next slide, we are now finalizing the phase 2 study. And what we have seen is that this is a dose-finding study, and of course we have a comparator in the study in lansoprazole, but it's power to show the differences in doses to be right when we're starting up the phase 3 study early next year. So going into the summary of this, next slide. We have a de-risked development program where we have a good relationship with the authorities, both in US and Europe. We know what they are requiring, and we actually are working on to deliver that, and we are confident that we can do that. We have the linaprazan, which is the active metabolite in our drug, and that has been studied in more than 2,500 patients and in all the animal studies, and no safety issues there, which we are also now confirming in our tox studies. And we have these active metabolites, which I have shown, which will definitely predict the outcome in the future clinical studies. So with that said, it looks very promising. Looking into the commercial factors, next slide. We have already said what is very much important to show acid control, but also looking into the next slide, I think it's interesting to see, next slide please, to see the performance Takeda has done in Japan, where they are now market lead. And this is a proof of concept that PCABs, firstly, there is a medical need out there. PPIs didn't do the job fully. So, of course, we need new drugs. And also PCABs is the new class that actually can meet this medical need. And going to the next slide, I think, though, it's important to differentiate versus PPIs. we definitely have a differentiator factor commercially with a shorter, with a much faster onset, hours instead of days, but also with better superior effect, which is important. Versus the other PCABs, we can say that we have, thanks to the cut in the Cmax, where we are now, we can use the full potential of the substance and have a full dose, and that gives you the full control of the acid during the 24 hours. And that is not the case for Takeda's Takecab, where they are. We believe that they have same issues as Astra had initially. So we also think that we can meet other symptoms that they will not fulfill. Okay, we can. I see this time is running. We can go to the next slide. I just wanted to mention we will not be alone in the market. We are estimating to have a full approval in 2025. Vonoprazan Takecab will be approved a little bit earlier than 2 years before us in the US in this indication. But as we have seen in the PPI market, this market is so big, so there is space definitely for more than one player. In PPI market, we have seen 6 players, and they have all been successful. Here we are estimating to have approximately 2 to 4 players in the western part of the world. There are some more Asian products that do have ambition also here, as you see. So next slide. I can just say the patent situation is good. Yes.
Sorry, just in the interest of time, I think we have to crack on to the Q&A, but we can leave this slide up.
Yeah, we can go to the so we have that in front. Please, next one. Next one. Next one. There, we can have that.
Okay, great. No, thank you for an interesting presentation. My first question was going to be on how Takeda has positioned Takecab in Japan, and how they sort of regulatory approval and the commercial positioning, as I understand it, being non-inferior to PPIs, but with a faster onset of action. And I'm just curious to hear how that differs from how you're thinking about it.
Yeah, I mean, of course, we will have, if you differentiate it versus PPI, of course, faster onset is important. But superior effect is also important. And since they have only done non-inferior study in Asia, they have problem to do that. So we will have definitely another factor that they don't have, at least not in the eastern part, or not in Asia.
Okay, alrighty.
And also they have focused on independence of food intake as well. You can take this whenever. PPIs you need to take, you cannot take it together with the food.
Okay. And just help us understand, Phathom licensed the US rights from Takeda. And just help us understand why Takeda wouldn't have pursued that US opportunity themselves, or indeed why there was such a lag between launching in Japan and then seeing the opportunity outside of Japan. Why did that take
well, you have to ask them, but no, I mean, of course we can always have guesses here, and of course we have investigated quite a lot why. But the problem, I think, from initially, they were a little bit insecure if the PCABs should work in the western part. Normally you get a very good result in Asia. You have seen that in the past with all these kind of PPI investigations. But I would say now that you have de-risked the case quite dramatically when Phathom has done their phase 3 studies and actually showing good results compared to what we have seen in Asia. And definitely, I think Takeda didn't maybe estimated that, and it was some kind of de-risk position they had. They will of course earn quite a lot in royalty income from Phathom, and I really I think they were a little bit insecure how this should be managed in the West, but obviously we see now that it works.
Okay. And then maybe just one question on the profile. You were saying how the Cmax has been brought down, and you prolonged that half-life to get that favorable product profile. I'm just curious, mechanistically, is there any reason to think that that higher Cmax that Takecab has, for instance, is necessary or a favorable feature in terms of getting that efficacy, and that you need a degree of high Cmax?
No. That is totally useless. Actually, they have. I mean, linaprazan initially they had 20 times higher than was needed to reach pH 4. Actually, we have, as it looks now in our early stage studies, we have even faster onset. So you don't lose anything by cutting it. It's only good. It's good.
Okay, maybe just one final question then. On your IP situation, we didn't have time to look at it. What does that look like? And then separately, there is, as I understand this 5 years of extended market exclusivity in the US if you go after H. pylori as your lead indication or initial indication. Is that on the table for you? Is that something you're looking at?
Yeah, definitely. We are looking into that, and we will do that, and we are working on that now. So, I mean, patent is one thing. We have the current patent is valid until, including the extension, is valid until 34-ish, 33 and 35. But also when you go with a new substance, you get the data exclusivity. In Europe, you get 10 years from registration, so that is at least to 35, and that is as strong as the patent, I would say. In US, you only get 5 years initially, but now with the possibility of a QIDP to prolong, to make H. pylori as the indication, then as a first indication, then you can prolong it by 5 years. You also get 10 years in US, and that's we will do this H. pylori and eGERD studies in parallel as phase 3.
Okay, Christer, perfect. We're all out of time. Thank you very much for an interesting presentation.
Thank you. Bye bye.